Well, welcome to Ortenzio Heart Center in Camp Hill, Pennsylvania. First of all, I like to congratulate Dr. Inoue and his colleagues for conducting a fantastic Japan Endovascular Therapy meeting in Tokyo. And this is a contribution of C3 to JET meeting this year. So congratulations, everyone, and looking forward to catching up with all my friends at C3 in June in Orlando. But at request of Dr. Inoue, I am recording a procedure here where we see a heavily calcified lesion treated with orbital atherectomy. This is a 64-year-old gentleman who has a known history of coronary artery disease as well as peripheral arterial disease. He has prior history of coronary artery bypass grafting and history of peripheral arterial disease. In 2010, he was seen at that time with a severe claudication and had treatment of the left lower extremity. At that time, the superficial femoral artery was heavily calcified and was treated with a balloon angioplasty and a 9 by 100 millimeter absolute bare metal stent. He was recently evaluated due to recurrent claudication in the left lower extremity, so almost 6 years later, and now has a chronically occluded left superficial femoral artery by Doppler study, and hence he was referred for angiogram. He also has treatment of his right lower extremity, which is also has stents, which are all patent. He has a history of iliac stents as well, which are patent as well. So let me talk you through our approach here, and then I'll explain the angiogram, and then our strategy of how we are going to treat this patient. So we almost always do majority of our procedure with a contralateral access. That's the classic way in 95% of our patients. We don't do that much antegrade access in our lab for the convenience and the ease of closure. All of these patients go home the same day after their treatment with a closure device. So that's what's done here. We have a 6 French destination Terumo sheath that's inserted from the right femoral approach into the left common femoral artery with the use of a 035 supracore wire, which was delivered from a diagnostic catheter. So this is his angiogram. This is his right femoral artery. As you can see, the bifurcation in the right common femoral artery is very high. The stent, there is a stent in the right SFA. So we obtained this access with the fluoroscopic guidance to make sure that we are in the common femoral artery, not through the stent. And then ultimately, when we are done with the procedure, we will be closing this femoral artery with a angiosil or a ProGlide type closure device. This is a catheter, diagnostic catheter in the left common, and you can see that there is some disease at the ostium of the SFA. There is some disease at the origin of the profunda femoris artery that's calcified, and in the mid SFA, you can beginning to see that there is a subtotally occluded superficial femoral artery. And if I take off the subtraction, you now can see the degree of heavy calcification that's present. Luckily, the previously placed stent, which is the absolute stent in the distal SFA, is widely patent with some mild disease. And he has significant disease of the popliteal artery with a small aneurysm also right in the mid segment of the popliteal artery. And you can see that there is a distal heavily calcified lesion in the popliteal artery just before the trifurcation into the tibioperoneal trunk and anterior tibial artery. So after placement of the sheath, I used a selective catheter and did an additional angiogram. This is something that we do quite frequently to determine the exact length of the CTO, as well as see if there is a micro channel that's present that could help us cross this total occlusion. So our choice of wires for crossing the total occlusions are either an 035 angle stiff glide wire from Terumo, or we use a Asahi 014 coronary or peripheral CTO wires. So in this case, I used a Confianza Pro 12-gram wire, which is what you see now on the screen. And with some minor manipulation of the wire, I was able to go through this total occlusion. And you can see that without much in a way of difficulty, I was able to cross this subtotally heavily calcified artery into the stent. So after crossing that, I used a Corsair microcatheter over this wire and took the wire all the way down into the distal popliteal artery segment, and then I was able to cross that second subtotal occlusion of the popliteal artery into a peroneal artery. So Corsair was then advanced all the way into the peroneal artery, and the Confianza Pro 12 wire was removed, and a proprietary 014 Viper wire, which is a wire that we use along with atherectomy device, orbital atherectomy in this particular case, was inserted. Then we attempted to do an IVUS exam, and we used a 014 eagle eye catheter, which is what we do. And IVUS catheter was stuck into the proximal occlusion of the femoral artery, where you can see the picture on the screen of the IVUS. And IVUS catheter would not cross beyond that. So we know that this is a very, very tight calcified lesion, because otherwise my thought was to cross the entire SFA in popliteal artery and perform IVUS examination of the whole segment to guide the treatment. But we cannot get the IVUS beyond the proximal SFA segment. So that's where we are in the procedure. And I will open this up for a discussion between our Japanese panel members in Tokyo to discuss what could be potential approaches of treatment and how to deal with this disease. As you can see here, if Jeff can focus on this device has an electric motor already inserted into the device, so it does not require an additional gas connection, unlike a rotational atherectomy device, and has a 150 millimeter length of a treatment zone, which they call it a throw, and it has 3 different speeds: 60,000 RPM per second, 90, and 120. And there are little buttons here to select the speed. This green button is a brake. It is connected to a what Orbital Atherectomy company calls a Viper Glide solution, which is almost identical to a Rotaglide solution in a saline bag, which is dripping through this device. This device also comes in 2 varieties. It comes in a classic crown, which is a relatively short diamond chip coating over the device in the center and is eccentrically placed, or a solid crown, which has a higher debulking capacity, and the diamond chip is coated throughout the entire surface of the device. So 125 is the smallest size available, and I've chosen a solid crown because I know I'm going to require a fair bit of debulking capacity in this case. So we are going to go ahead and use this 125 solid crown in the SFA as well as into the popliteal artery, into the peroneal artery. And once we have created a channel, then we can see if we can reattempt to perform IVS examination to learn about this occlusion more, and then guide our treatment based on that IVS examination. So I'm going to choose 120,000 RPM because I know that there is at least a tiny lumen through this artery, and I don't seem to think that I need to go at a lower speed. But if I have a potential for getting stuck, or if there is a high degree of deceleration into the occlusion, I can always reduce the speed. So the technique of orbital atherectomy is very similar to rotational atherectomy, is to do packing motions. And you should spend some time in the occlusion to allow the device to work and debulk the stenosis. So you can see I'm getting a fair bit of resistance in those areas. Okay, now we're going to try to advance the device further down into the popliteal artery. If the device would go through the stenosis, and it did, and do the debulking in the distal popliteal artery into the peroneal artery. So you can see right there, my burr is basically stuck into the occlusion. And we just got into the tibioperoneal trunk now. And this is the popliteal disease distally. And you can see that huge amounts of calcium. And you can see the orbital atherectomy cut at 3 o'clock. And here's a little bit higher. And now the vessel is normalized. Well, it's not normal, but it doesn't have very severe disease. It's about 4.5 millimeters in diameter. Now the vessel is getting bigger, and this is where you see that small pseudoaneurysm at 12 o'clock position. Whether that is a pseudoaneurysm or whether it is a small true aneurysm, we don't know, because that segment has never been treated before. This is the distal SFA, a lot of disease there. Now, at least by reading the report from the last intervention in 2010, it was noted at that time that the entire SFA was ectatically dilated and aneurysmal. And that's why the stent chosen was 9 millimeters. And you can see that the stent actually looks fantastic. There is no real problem within the stent. Looks very nice. And now we are getting into the disease segment, which is the target of orbital atherectomy. And you can still see that I still see a fair bit of calcium there. More calcium. So orbital atherectomy has done a fairly nice job here. So this is our another very tight area. So what I'm going to do is I'm going to use one size bigger device here to debug this a little bit more so that we can have a proper expansion. And I'm going to choose a 2.0 classic crown to debug. So this Sterling is a 014-018 balloon, so I don't have to change the wire. The reason why I haven't changed and exchanged the wire to 035 is I also want to dilate from below the knee vessel into the popliteal artery. So I'm going to take a picture here to judge how this looks here now, as we will have some flow, so we can determine how to dilate this distal pop. Dilate it, and then I will attempt to put a second wire into the anterior tibial artery, and we'll attempt to do a kissing inflation there. So I want to show you the chocolate device. So it's practically almost a 19-hole self-expanding stent over a balloon. And what it does, it allows the balloon to open simultaneously throughout its entire length. So we'll go ahead and put the chocolate in now. And hopefully we can get the chocolate balloon down there. So we were lucky, the chocolate is down there. Okay, go ahead. Yep. 14. Okay. So what I'm going to do now is I'm going to change out the Viper wire for a regular wire through this chocolate balloon. So my favorite wire to work in the periphery is Grand Slam wire. So I'm going to put a Grand Slam wire through it, and then I'm going to put a second wire into the AT if I am successful. So I will use a Miracle 6-gram wire for anterior tibial artery, and then we will do kissing inflation. So the distal popliteal artery in the panel can also discuss this, but in our lab we feel that unless we do a kissing inflation, because of the size discrepancy between the distal popliteal and the below knee vessels, we usually don't get a good balloon angioplasty result, which is what we are trying to achieve. Okay, so after doing the 3-5 chocolate balloon inflation from the tibioperoneal trunk into the peroneal artery, now I have a second wire there, and initially I tried to get into the anterior tibial artery with a Miracle 6-gram wire. That did not succeed, so I put a Corsair catheter, and that's the Confianza Pro 12 that I was using earlier. I used the same wire again to get into the AT, and you can see that the wire easily went down without much in a way of difficulty. So now I have a 2-3-5 by 30 millimeter Emerge NC coronary non-compliant balloons, and we're going to go ahead and do a simultaneous inflation. So after the kissing inflation, So I used two 3.5 non-compliant coronary balloons and a 2-minute to 3-minute inflation in both vessels. And this is the result. And it's not perfect, but it's very acceptable. You know, if I perform a complex bifurcation stenting here using a coronary stent, there are a lot of potential issues that can come up in future. He's a young patient, so I think this result is acceptable, and we'll leave it at that in this area. So now we'll refocus our energies to the SFA and the remainder of the popliteal artery. So I'm going to go ahead and take one of the wires out here, all the way into the distal SFA. And here we can consider a DEB. But before we do that, let's IVUS one more time. So this is an impact DEB that you guys are very familiar with. Pretty straightforward, just like any other balloon. And we'll do a prolonged inflation with it as recommended by the manufacturer. And the clinical data. Okay. This is the longest impact DEB that's available. This is 60 by 120. Oh. Yep. So 1-to-1 sizing based on the intravascular ultrasound.
6,
8, 10. Okay, so this is at 10 atmospheres, 1-to-1 DEB for maximum apposition. Apposition is critical, and then prolonged inflation. So I'll keep this inflated for 2 minutes, and then I'll be back with you with a repeat angiogram. So this is the post-balloon angioplasty DEB result in the popliteal artery, and I think it's very acceptable. So I'm satisfied with that. We'll continue to observe this small popliteal aneurysm with a repeat Doppler examination every year. And now I'm going to go ahead and implant a 7-millimeter complete SC stent into the mid SFA, and then I'm going to post-dilate the stent with. So I'd say this is a very acceptable result in this extremely complex stenosis and the use of orbital atherectomy with intravascular ultrasound guidance, and then ultimate angioplasty and stenting. So this concludes this procedure here. I thank you for your attention, and I welcome everyone to attend C3 in June in Orlando in 2017. It's going to be a fantastic meeting with a multiple complex lesion subsets such as this one to increase your skills and your knowledge and sharing your experience with the colleagues from the rest of the world. Thank you.